Hi! Last week we discussed our first case of double triggering, commonly known as breath stacking. Today we'll revisit that case and discuss additional ones. Back to last week's case, you can see instances of a second inspiration being triggered shortly after the end of the prior inspiration. This characterizes what we would describe as double or multiple triggering. It turns out that there are different causes for it and the treatment varies. The first cause that we'll review today is called early triggering. Last week, we discussed this part of the waveform in red, but this week, we'll discuss the one in blue, just to see some variety. Using our systematic approach, we know that the patient is on APV, where pressure is the limit variable. We focus then on the flow time waveform. We'll remind ourselves of how a passive breath looks like in APV. Then we'll compare it with what we are currently seeing. The blue arrow here shows an inspiration that is passive through its entire duration. Note how the shape of the flow waveform is similar from our reference passive picture on the right, although flows are lower. Then, when it comes to expiration, instead of us seeing high negative flows that slowly decrease, like on your right, we see early negative flows that abruptly end, leading to a second inspiration as shown by the white arrow. The blue dashed line shows how passive expiration would look like, and the blue shaded area indicates the difference between the observed and the expected waveform of a hypothetical passive patient. Guess why observed flows are more positive than what we would expect? Yes, because the patient is contracting their inspiratory muscles during early expiration. The big picture interpretation here is that the ventilator triggered the breath at the blue arrow before the patient started exerting effort at the white arrow. This is why this dyssynchrony receives the name of an early trigger event. The vent started inspiration before the patient started inhaling. But how do we treat this? Well, there are two simple effective options. One is to delay ventilator triggers. By decreasing the respiratory rate, we give patients more time to trigger their own breaths, effectively solving the problem. Note how in this case, by dropping the set rate from 24 to 14, now the patient is triggering every breath at a rate of 19. If there is no ventilator-initiated trigger event, there can't be an early trigger. Instead of dropping the mandatory rate to allow the patient to trigger their own breaths, we could use a mode where there are no ventilator-triggered breaths. Can you think of what that mode would be? Yes, pressure support. Here's a picture of how the ventilator looked once we transitioned this patient to pressure support. This also effectively treated the early trigger events. Note that these solutions were not only sedation-free, but the use of sedation here could have been detrimental. If you sedate the patient too heavily, you may be unable to lower the rate or to put them on pressure support, since they now may have too little respiratory drive to trigger at a reasonable rate. Obviously, there are situations in patients with severe respiratory failure where neither decreasing the rate nor placing the patient in pressure support is clinically appropriate. In those scenarios, you have little option but to increase the depth of sedation if you want to abolish this abnormal patient-ventilator interaction. We will now discuss another patient-ventilator interaction that may also lead to double triggering or breath stacking, but requires completely different treatment. Of note, in this Bella Vista ventilator, breaths triggered by the patient are shaded, as seen with all breaths in this image. The mode here is volume control with a partial descending ramp flow waveform. Since flow is the limit variable, we will look first at the inspiratory pressure time graph. Remember, the ventilator controls inspiratory flows, so we shouldn't expect to see any changes in that part of the waveforms secondary to patient effort. However, we will see signs of patient effort in the expiratory portion of flow waveforms, since the ventilator controls pressures in expiration, regardless of the mode we use. Let's put here on the side a picture of how passive waveforms look on volume control with a partial descending flow ramp and focus on the middle breath. there is evidence of inspiratory effort throughout inspiration. The patient triggers the breath, as evidenced by the fact that the waveforms are shaded, and the shape of the waveform shows significant negative deflections compared to passive waveforms on the right. Let's turn now our attention to the expiratory part of the flow waveforms. We see an early positive deflection that crosses baseline. This indicates that inspiratory effort extends through inspiration into expiration and almost triggers a second breath. The fact that the patient was active from the beginning of the breath all the way past the end of the cycle event indicates that patient inspiratory effort in blue is longer than what we're setting for their inspiratory time to be, depicted here in red. This characterizes early cycling. Our cycle variable is dictating an inspiratory time that is shorter than the patient's neural inspiratory time. Back to the original image, note that with the first and fourth breaths, double triggering happens because the inspiratory effort in early expiration is strong enough to meet the trigger threshold, leading to double triggering. In general, the treatment for early cycling involves lengthening your inspiratory time or using a mode such as pressure support, where the cycle variable will allow for prolonged effort to lengthen inspiration. In this case, pressure support was not an appropriate option given the patient's severity of the respiratory failure. We were ventilating them with a main goal of safety. You could try simply lengthening the duration of inspiration by lengthening inspiratory time or decreasing inspiratory flow rates, depending on the ventilator you're using. However, if you don't change the tidal volume, by lengthening the duration of inspiration in volume control, you inevitably end up with low flows, and this will frequently lead to another abnormal patient-ventilator interaction called flow dyssynchrony, as we'll see later. Frequently, in volume control, the reason for patients wanting to extend their inspiratory time is because tidal volumes are set lower than what they demand. Note how low tidal volumes were in this case. The patient here was on ECMO and tidal volumes were set to only 200 mL. Although increasing tidal volumes would often fix this problem, it may not be clinically appropriate. For example, in patients ventilated for severe ARDS. In those cases, the best next step for this dyssynchrony is suppression of respiratory effort with more sedation or even with the use of paralytics. We'll continue our discussion on multiple triggering next week, since this is such an important, frequently encountered, and interesting topic. I'll see you then.